Thank you. So I was tasked with talking about the alternative therapies to GERD adolescents. I have no disclosures except I'm not anti-Nissen. So do children really outgrow reflux? So when you think about this, you have to talk about the appropriate intervention, what it's going to be, and for the age and size. Sometimes the size will go down. Adolescents can be small. So patient selection is key in any intervention you attempt to do, and that bases on age, weight, neurological status, is the child an eater or a non-eater, and what is the quality of life at the end of that intervention. So I'm going to talk a little bit about maximal medical therapy, gastrojejunostomy tubes, transoral incisionless fundoplication, or a total esophageal disconnection. And I will briefly talk about Linx, although this is not used in kids under 21. So standard medical therapy is really a pretty aggressive regimen, including 3 months therapy with high-dose H2 receptor agonists, and then a 12-week decrease in that tapering dose, which is really 6 months of therapy. And I can tell you a lot of kids aren't coming to us with that type of intervention. In one study back in 2001, the comparison of surgery to medical therapy had a lower total cost, but I should mention that these were all open surgeries, Nissen fundoplications. So in terms of gastrojejunostomy tubes, this is something that kids end up with when they see GI first, because they say, oh, you can't have a surgery, we're going to just put a tube in. There haven't been any guidelines with regards to a gastrojejunostomy tube versus a Nissen fundoplication in G-tube. One such study looked at 3 retrospective reviews with a large number of children, 556, 431 of which underwent fundo and G-tube, and 125 received no G-tube. In comparing these groups, there's no difference in pneumonia or rates of mortality. There was a trend toward major complications with the fundoplication versus GJ, but not statistically significant. There were many more minor complications with the GJ, probably related to dislodgements, radiographic replacement and such. But none of these studies reported quality of life data, as Karen mentioned. And there's low quality of evidence for either approach. So most of the time you're going to do what you do. Our colleagues in Canada don't do Nissen, so they're going to get G-tubes. So the first endoscopic fundoplication with esophagus was done in 2005. Purported to be ideal for patients with reflux unresponsive to PPIs or chronic GERD, small hiatal hernia. I actually went to Columbus to learn how to do this 10 years ago. It's a pretty complicated device, and I did a couple of them, and I'll show you the results of what most studies have shown. So essentially, it's a device which plicates the stomach from the inside. It's a totally endoscopic technique and creates a valve inside the stomach with proline sutures. And the stomach is sucked in against the esophageal wall to create this fundoplication. So most of the studies, in adults, and there's one study in children, show that the number of reflux episodes are decreased in TIF patients compared to PPIs, but there's no decrease in acid exposure or reflux episodes. And this is from 5 randomized controlled trials and 13 prospective observational studies. The one thing that we did see is that most of the patients went back on PPIs, but there was a 69% satisfaction rate. Another adult study, similar results. This is actually from Ohio State, where 57 patients were followed long-term. Many had improvement in their GERD-related quality of life, but 12 ended up going on to Nissen fundoplication or anti-reflux surgery. 73% were also on long-term PPIs, but again, 78% of patients were satisfied. So the one pediatric surgery that we see is out of Michigan, and these are high-risk patients, all neurologically impaired. Many had prior fundoplications, and they followed these patients up for a median of 5.5 years. 63% had 1 or more Nissen fundoplications prior to the TIF procedure, and 6 symptomatic reflux persisted in over half. 4 underwent reoperations, including 1 Nissen and 3 esophageal disconnections. 82%, again, as in the adults, are still on anti-reflux meds. Recurrence rate was high, but in this high-risk population was considered acceptable. The complications are low, and at least a subset of patients received durable benefit from the TIF, about 45%. So now here's the big gun, a total esophageal disconnection. So this is has been used in patients with GERD after failed fundoplication in neurologically impaired patients. It's a Roux-en-Y esophageal anastomosis and JJ anastomosis with a gastrostomy tube in the remnant. And this is just a drawing of this particular procedure. And if you look at it carefully, you'll see that they tunneled the roux limb underneath the pylorus, which I think this is an error here. So that's going to be a little difficult to do. But essentially, it's a Roux-en-Y esophageal disconnection with a G-tube in the remnant stomach. So it's advocated to eliminate GERD in neurologically impaired children. So if you remove the stomach out of the equation, you can remove GERD. Not unlike if you do an amputation, you're going to remove foot pain. But there's higher rates of complication requiring reoperation in the neurologically normal patients in this particular series, 32% versus 17%. So it's a hard sell to tell a family that you're going to disconnect the esophagus in someone who eats and is neurologically normal. But they have a fairly large series, and this is from Japan. And this particular series from the UK had 40 patients, 33 of which were primary disconnections, and 7 were failed fundoplication patients. But they had 100% resolution of GERD and mean follow-up of 8 months, or 13 months. And this was done by an open approach. Another series from the UK showed, again, similar resolution of GERD, 98%. Complications are fairly high at 18%, and including 1 death. A laparoscopic approach has been performed out of Richmond with 22 patients, again, 1 mortality. Although when they polled their families, they were actually happy with the quality of life after disconnection, as well as the improved ease of the caregivers for taking care of these adolescents. So I'm just going to mention quickly Linx. So Linx is something that has been advocated and done in adults. It's just a magnetic chain around the GE junction, which opens up with a food bolus. From the 2017, the Technology and Value Assessment Committee at SAGES assessed the safety and efficacy or effectiveness of this device. And it was deemed to be effective in treating GERD for adults, but safety was not established for adolescents or anyone under 21 or those with prior esophageal interventions or gastric surgery prior to this intervention, as well as hiatal hernias over 2 centimeters. So why not Linx in children? So back in before 2005, when some pediatric surgeons were dumb enough to do bariatric surgery, we were doing gastric bypasses. And we always thought, oh, well, we should do a sleeve. Sleeves are better. They're going to work better. And then when I retired from bariatric surgery, later on, people started doing sleeves. But for the Linx, why don't we establish an IDE or do some clinical trials so that we could start offering this to adolescents who may benefit from this procedure as just something more invasive. And I can tell you, pediatric surgeons have always lagged behind y'all adult colleagues who, that's why we come to this meeting, in everything, bariatric surgery, GERD, foregut operations, achalasia in terms of adopting POEM. And I debated Dr. Ponsky in the back there a few years ago about POEM versus not POEM. And again, I got the rap of doing not ready for primetime POEM, and just like I'm getting esophageal disconnection today. So anyway, time to move on. We can take care of these kids. So in summary, there's several options for GERD in children in lieu of anti-reflux surgery. Oops. I think we skipped ahead.
Oh, that's me. That's my slide.
Yeah, how did I get back?
Can you go back to his slide?
Okay. So options range from maximal medical therapy to a radical esophageal gastric disconnection. Patient condition, surgeon experience, and what's best for the child should be the paramount consideration. Newer therapies such as Linx may be applied in the future. And final thoughts. Maybe less is more, but is a lot more too much. Open fundoplication, even after redo, after open, is not a standard of care, and a surgeon should not perform an operation he or she does not know how to do well. Thank you.